Good afternoon, everybody. Thank you for coming. My name is Bo Farnhall. I am the Dean of the Manning College of Nursing and Health Sciences. And we're very happy to organize this symposium on health equity as part of the inaugural activities of our Chancellor. So we're going to get started on time. And our first speaker is Nicole Keith, who is the Executive Associate Dean of the School of Public Health at Indiana University. She is also a former president of the American College of Sports Medicine, which is the largest sports medicine organization in the world. And she has an extensive research record on doing physical activity interventions and physical activity programs in the community. She's a very accomplished researcher, and she probably doesn't remember this, but I first met her when she was a master's student 3 years ago, maybe. So I've known her for a long time. And so without further ado, thanks for coming, Nicole, and the floor is yours.
Thanks, Bo, and thanks everyone for coming on this Friday afternoon. I'm surprised there are actually people in the room. It's great. So my talk is about taking steps towards health equity through cardiovascular fitness, and I will just keep going. So I was afraid that I wasn't going first, but since I am, I get to define health equity, and health equity describes differences in health outcomes that are avoidable, or they're unwarranted, or they're considered to be unethical or unjust. To realize health equity, all people, regardless of their demographic characteristics, need to have the opportunity to be healthy. And achieving health equity through cardiovascular fitness is a viable solution. So here I present the leading causes of death in developed countries. And while respiratory disease and lung cancer are pacing closely behind cardiovascular disease, cardiovascular disease remains the leading cause of death in nations where populations should have access to opportunities for both health promotion and for opportunities to receive health care. This figure demonstrates disparities in cardiovascular disease among adults who are, see if this is working, it's not, okay, who are non-Hispanic Black, non-Hispanic White, and non-Hispanic Asian. And it shows that non-Hispanic Black adults experience poor cardiovascular health outcomes at a higher rate compared to the other races presented here in the United States. We understand that almost all diseases are caused by interactions among our genetic makeup, the environment in which we live, the environments in which we work, learn, play, and pray, and our behaviors. While we can't control what we've inherited from our parents, individually and as a population, we can influence lifestyle behaviors as well as the communities in which we exist. So despite many notable advances in treatment and management of cardiovascular disease remains the most frequent cause of mortality in all human populations. This is avoidable. In fact, data suggests that for the most part, 50 to 90% of cardiovascular disease is modifiable, and it's a preventable condition as well. So I want to acknowledge that there are risk factors that are unavoidable, such as age, gender, genetics, and race. However, there are several modifiable risk factors that can be managed through lifestyle behaviors and interventions when necessary. So this figure demonstrates multiple variables that feed into poor cardiovascular health, including elements of the built environment that are in the green boxes at the bottom of the slide, lifestyle behaviors that are in the purple boxes that may lead to obesity and or influence the physiology that contributes to cardiovascular disease and poor health outcomes. Physical activity, which is what I'm going to talk about now, because that's my thing, is a solution to poor cardiovascular disease outcomes for everyone, and it's a solution to addressing health disparities in cardiovascular disease outcomes. If the track is closed, one can run in their neighborhood or at the park. And if an individual doesn't have the ability to run, they can walk, because walking or propelling a wheelchair are suitable substitutes. If a person doesn't have the time or ability to walk or run in formal exercise, they can expend energy through active transportation or simply completing chores. Moving from place to place, sweeping, mopping, dusting, vacuuming, gardening, mowing the lawn, all of these tasks use large muscle groups that count for physical activity. So don't feel like you can't exercise, because everything that uses large muscle groups counts. So this is a social ecological model of physical activity, and it's patterned in the same manner as the social ecological model of health. It describes how constructs fit into one another and can influence whether or not a person will be physically active. Physical activity and active living are central to the model, which includes individual determinants such as beliefs, gender, age, and ability. The social environment, such as culture, social cohesion, income, and equity. The built environment, including transportation, land use patterns, community design, and green space, and the natural environment, which includes air, water, weather, and topography. Here I've listed some of the social determinants that explain greater physical activity participation, including greater health knowledge and better problem-solving skills that can help people make more informed choices when it's possible to make a choice. People are also more likely to be physically active when they have more flexibility in their schedules and the social support to do so from coworkers, friends, and/or family members. As professionals, it's our responsibility to improve social norms to help make the active choice the easy choice. Both structural and environmental factors also contribute to the social determinants of physical activity. And here I list the built environment, which includes macro environmental factors such as enhanced green space, sidewalk connectivity, and traffic calming measures that contribute to more walkable communities. The other influences that I list here include quality housing, transportation, recreation facilities, and those are also macro environment facilities that contribute to the physical activity and health equity. But I'd also like you to consider microenvironmental factors. These factors are what's inside the places where people work, play, learn, and pray. These also contribute to opportunities for individuals to be physically active. So addressing both macro environmental and micro environmental factors to achieve health equity through physical activity is the low-hanging fruit. Physical activity has the potential to positively influence every societal sector and social justice issue. So on the next several slides, I'm going to present demographic characteristics and where there are gaps in physical activity among these demographic groups. I look at these as opportunities to improve physical activity, and I'll present some strategies after that to change both generally and related to physical activity more specifically. So research shows us that women are less physically active than men. We have to identify ways to help ourselves, as well as our mothers, our aunts, our sisters, our daughters, become more physically active by building the science, and again, through education, advocacy, and policy. Gender plays a role in the social determinants of physical activity. Men are more likely than women to meet the physical activity guidelines. And when compared to other individuals of their age, girls and boys between the ages of 15 and 18 spend more weekday minutes. Boys spend more weekday minutes than girls, and moderate to vigorous physical activity. And this also suggests, based on this slide, that when boys go to school, they're more active than when they're at home. And so it's important for us to provide physical activity opportunities for both boys and girls and men and women within our communities. So I'm a scientist at the Indiana University Center for Aging Research, and my focus is on older adults. And so I like to talk about them because I'm so stunned by how frequently older adults are excluded from the conversation. These are valued members of our society who benefit from physical activity in the ways that are the same as everyone else, and yet, as they age, their physical activity, and I should say our physical activity because I'm in this group, our physical activity levels become lower. 27% of adults who are 50 years of age and older report no physical activity outside of work in the past month. And as we age, the percentage of adults who are physically inactive increases. And among older adults, physical inactivity was highest among women and underrepresented minorities, or with people who have one chronic disease or more. People with less education and older adults with a higher BMI are also less physically active. These are the people who could benefit from physical activity the most. Affordable opportunities that are appropriate regardless of chronologic and physiologic age are a must in order to achieve physical activity for all. A child with a disability is less likely to be physically active and more likely to be excluded from opportunities for physical activity, even when they exist. As a child ages, their race and their socioeconomic status do not account for their physical inactivity when they have a disability. As that child grows up, they're 3 times as likely to be a less physically active adult. And adults generally diagnosed with a physical disability also have more chronic disease. And 54% of all adults with disabilities, regardless of if it's a physical or intellectual disability, 54% of those adults get no physical activity. Research focusing on physical activity participation among sexual minorities is quite limited, and much more work is needed. Between 57 and 78% of lesbians don't engage in sufficient amounts of physical activity, and nearly 13,000 youth and adults who identified as sexual minorities reported participating in 1.2 to 2.6 hours per week of less moderate to vigorous physical activity when compared to their counterparts. And lastly, there was no difference in physical activity participation when gay men and heterosexual men were compared. Race is also a factor in the social determinants of physical activity. And while the same percentage of Blacks and whites report meeting the US physical activity guidelines, fewer than 3% of Latinos report meeting the guidelines. There are also disparities in the percentage of children and youth who do not meet the US physical activity guidelines. Black girls are least active, followed by Latina girls, white girls, Black boys, Latino boys, and white boys. Racial disparities are prevalent in more than just Black people. And as I've just presented in the slides previous to this, the minority groups impacted are more than just racial ethnic minorities. So what do we do about it? So my first recommendation is to use social equity to move towards equity in physical activity. By improving access to physical activity resources, addressing basic needs so that some of the barriers to physical activity can be removed, assessing whether there's maintenance in health and well-being, supporting economic development, and encouraging participation in physical activity during normal public life. These steps are going to look different depending on the population and the community. So I acknowledge that communities can be quite diverse and one size does not fit all. However, there's some general steps that I recommend in order to build social equity, and these include facilitating meaningful land use decisions, promoting clean, safe environments, strengthening existing communities, and providing transportation options, improving access to opportunities for health, and promoting resources and preserving and building upon existing community features. I recommend not approaching this from a deficit model. Communities have so much to offer. It's also important to advocate for those who have a limited public voice and build inclusive structures that support engagement and use dialogue that reflects diverse social identities and generate ideas that build capacity and enhance community and quality of life. Questions that are necessary to tailor steps towards health equity through physical activity include, what are the most important ways physical activity influences equity? What are the opportunities to address equity while increasing physical activity opportunities? And how can goals and metrics be developed to make equity relevant and achievable to its implementers? When forming coalitions, implement real change through cross-sectoral strategies with social equity stakeholders who could be included. So who are these social equity stakeholders? Well, they're the people who are directly involved in community redesign. This includes residents, city planners, and engineers, the communities that surround the redesign community, and the people who are impacted by the production or destruction of resources. And somebody asked me a question about that when we go to the Q&A. Okay. A careful consideration for communities themselves must be given, including ensuring community and quality of life are accessible, affordable, and engaging. There must be individual health and well-being for the residents, users, and the members of the surrounding communities. And attention must be paid so that the community members aren't moved out of their jobs, their skilled wages, and the benefits of education. Following these steps will help avoid gentrification. So I put up this slide to show that people tend to be happier among homogeneous groups. This group might be different, but think about it. When you came in, did you sit by somebody who was familiar to you? Did you sit with people you know right now? Someone with whom you've had a previous interaction, or did you sit by somebody new? So maybe this group is different, except for I can see you nodding, so you're not. And so that's okay. But whether or not you're comfortable with different people, people are really most comfortable where there's trust and social cohesion, and that's in homogeneous groups. But when people are put together from diverse groups, comfort is reduced because people have different backgrounds and different experiences. And as a result, these constructs of trust and social cohesion seem to go down. However, diverse groups perform better. This is true both intellectually and economically, that the most successful societies, systems, and organizations intentionally build diversity in order to address health equity. While we've come a long way in addressing disparities in physical activity, there's still so much more work to do. In addition to what I've described here today, many populations that I've listed earlier are also underrepresented in physical activity and health research. We recommend engaging in systematic and ongoing data collection and analysis that includes those populations who experience low physical activity. Another potential problem with building the evidence on the impact of physical activity and health outcomes is that researchers may have difficulty enrolling vulnerable populations in an investigation. There are multiple reasons that are due to the investigator, the data collection methods, the location at which the data are being collected, and the potential participants either not trusting or misunderstanding the research process. So for example, the investigator may wish to avoid necessary extra steps to seek research participation. Also, the investigator might not find the communities in which vulnerable populations live accessible due to the geographic location. In terms of data collection, potentially participants may not fully understand how sharing their data might benefit themselves or their loved ones, either immediately or in the future. And the site where the data are being collected also might be inaccessible to these individuals. Unfortunately, the historical research and medical abuse of certain vulnerable populations also makes building the evidence among underrepresented minorities and health disparate individuals. So I recommend collaborating with a culturally competent research team who can address such barriers with understanding and empathy while convincing vulnerable populations to engage in research. Other methods to engage vulnerable populations in research are effectively communicating shared goals of the participants' needs and the research aims, and to provide evidence to the communities and the potential participants that these investigations are legally obligated to follow strict research ethics and provide better access for potential participants to research by conducting the study at the community location or offer transportation to the research participants so that they can connect with the research team without using their own resources. The message to move more in order to improve health is more important today than ever before. Physical activity is essential to human health. It's imperative to educators, healthcare providers, public health officials, and policymakers. We must communicate the importance of physical activity to everyone, regardless of their demographic status, and provide directions on methods for people to be safely physically active, no matter where they live, work, play, or pray. So I've presented a lot of information today, and you have to digest it in the best way you can, but I've generated a list that summarizes some information in my previous slides. So look for changes that you can influence through the social ecological model of physical activity. Understand how the communities where you live, work, learn, pray, and play can impact physical activity. While working to make a better today, you can't forget yesterday, so it's really important to understand how people got to where they are and that history is an important influence on the present. And remember, diverse groups perform better. Lastly, don't forget to build the evidence and build the evidence with teams who look like the people we would like to influence. Thank you for your time.
All right, our next speaker is Ludmila Svoboda. She's a nurse from Dana-Farber, and she is the chief nurse for health equity in cancer. And she's been involved in oncology work for a long time. And we're very happy that she agreed to come and talk to us and will probably give us more of a patient perspective for inequities in cancer. So, Ludmila, thank you.
Thank you. Thank you, Bo. Can you hear me okay? Good. So Bo has me on a very tight schedule. You know, I tend to go off and present a lot of patient anecdotes and stories, but he said, Ludmila, 20 minutes, chop, chop. So I'm going to do that. And so I'm the nurse director for the Cancer Care Equity Program at Dana-Farber, and I'm a Czech immigrant. I came to the US via many different countries with a political dissident family. And you know, as soon as we landed in Newark, New Jersey, it became very clear to us, my nuclear family and I, that there are different Americas, right? That this is an incredibly segregated country, and that it's not like, you know, Baywatch or whatever, you know, they were feeding us on TV in the East. So disparities and oncology has always been my professional love, and I'm really honored to be here with you. Learning objectives, we can, you know, I'm just going to talk about mortality, morbidity, and so forth in the most common cancers, breast, lung, prostate, colorectal, and then I will talk about a local intervention that we started with my physician partner, Dr. Christopher Lathan, right here in Boston. So cancer disparities, right, affects everything from screening rates to incidence, mortality, morbidity, prevalence, survival, stage at diagnosis, goes into survivorship, end of life care, and then, you know, the financial burden surrounding cancer disparities is much more profound in communities of color. This is from the American Cancer Society, and you know, the first quote, I don't know if you can see it, it's from, you know, Dr. Islami from ACS. we have come a long way, but the disparities gap is really getting bigger again because of the cost of novel treatments, and personalized cancer medicine and all of these, all of these technologies that lower resourced communities, irrespective of race and ethnicity, don't have access to. Rural communities, those with lower socioeconomic input, and are still dying at much more significant and disproportionately higher rates. And then globally, right, I had the honor of working with Dr. Paul Farmer in Rwanda and Haiti. And, the cancer burden is also growing globally because people are living longer. A lot of the infectious diseases, are sort of maintained at a status quo. And then people are being diagnosed with cancers and don't have necessarily the screening and so forth resources that we have and that historically marginalized communities in the US don't have either. And then something that I'm seeing more and more every day through the patients that I see, and I see over the last 12 years, I've seen hundreds upon hundreds of patients, that a lot of our patients are coming now from the African continent, migrating maybe through Brazil, walking up to the US border, coming to Massachusetts, or now coming from Haiti, and coming with generally preventable cancers at late stages. So we're seeing a lot of young women with advanced cervical cancer. So Boston, I spent the last week looking at the 2023 Boston Report of Cancer that's published by the Boston Public Health Commission. I've linked in my references to it. There's every imaginable statistic and graph, and it really shows in great detail screening rates, incidence and mortality across race, ethnicity, housing, right? Whether a person has stable housing. It's more and more a really central issue to our patients' lives. Income, our patients underemployed, unemployed, folks that are retired tend to screen at greater rates. But, regardless of all of these, statistics, across the most prevalent cancers, mortality is still highest in Black women and men, and that has not budged. And these are residents of Dorchester, Roxbury, Jamaica Plain, Hyde Park, and Mattapan. And so the program that I will share with you that I help build focuses on these neighborhoods. They're Dana-Farber's priority neighborhoods. And they're also, this is informed by our community needs assessment that we do, great detail, interviews, focus groups with community residents, and that you can look at as well. So why, right? And this is why we founded the Cancer Care Equity Program. It's really the big elephant in the room. When I first started working at Dana-Farber, having lived in New York and practiced in really diverse patient settings and, Native American communities, why is it that in Boston, where we have these academic medical centers at every block, incredibly elitist programs with the most cutting edge medicine, how come we have such profound disparities in cancer care in 2024? So, and I can talk about this from the heart. I have seen hundreds of patients. Personal health is not a priority for patients from historically marginalized communities. It's survival, paying the rent, paying electricity, and then maybe down towards the bottom, I got to take care of my health, right? Our patients work multiple jobs to make ends meet. And these jobs don't give paid time off for appointments. So every time, Ludmila, if I come for this appointment, I will not get paid, and the cascade effect of then my check will be short and so forth. This is right here on the doors of Dana-Farber, right? Stable housing is, since I've done this work in Dorchester, Roxbury, et cetera, it started 12 years ago, housing has become more and more of a problem. We have many more homeless patients, and they're being pushed out into the periphery due to gentrification, lack of reliable transportation. And then PCPs are really overburdened. They have 15-minute visits, and each patient has a host of comorbidities, doesn't speak English possibly as their primary language, has PTSD, possibly has, substance and or alcohol use disorders as well. And so one of my PCP colleagues years ago said, I'm just putting out the most pressing fire at every visit. So longitudinal health plans and screening and so forth oftentimes fall to the wayside. Colonoscopies, we know, take a several-day prep. Somebody needs to have an accompaniment. Somebody else has to take off in the family. And fear of the healthcare system is also something that I hear all the time. And I hear, oh, you experiment on people. And, and like the first speaker said, this sort of collective memory of Henrietta Lacks and Tuskegee and so forth lives really true and central in our communities, and lack of formal education and health literacy. And I say formal education because I find the patients that I'm lucky enough to work with incredibly smart and incredibly resilient. They just have not had the chance to go to school. And then coordinating the healthcare, the care across a really complicated, fragmented healthcare system. It's really hard when you have cancer. It's a new language. It's a completely new reality. And then all these barriers on top of it. It's really difficult to navigate this. So in 2012, Dr. Christopher Lathan, who is one of the only Black physicians, oncologists at Dana-Farber, he had trained at BMC and then came to Dana-Farber, and he would be here today, but he's in Paris, so good for him, yay. But, he founded the Cancer Care Equity Program, and he really took a chance on me. He saw something in me, and I do speak 5 languages, so that helps, but he did see something that I could really, transcend sort of and connect really well and in diverse communities. And that's definitely something that has changed me and made me a better human. So we founded this program to address this elephant in the room. How come on the other side of Huntington Avenue, a mile from Dana-Farber, patients are not coming to see us? And, and these stark mortality rates among men and women of color are still happening. So I just want to show this because it was first just Chris and I, and then in 2020, and this is what he always says, and as a Black man, he can say, he says, Ludmila, America discovered racism in 2020, and then we got all this funding, and now we have a really robust team. So, but it was he and I going to the clinics that the partnerships that we formed within federally qualified health centers in 2011. So we hold outreach clinics in partnership in federally qualified health centers, and we help the primary cares work up complicated cases, and then we navigate patients to where they want to go. So it's really important to note that this is not to get patients, but to get the patients if they want to go to BMC, if they want to go to Tufts, if they want to go to BI, wherever it is they want to go. For us, it's a social justice issue. So we have a navigator, a PA, myself, et cetera, and we help patients to really close that gap between diagnosis to connection to care. This is our team. How am I doing on time, Bo? Okay. He's laughing. All right, 5 minutes. Okay. All right, so we recently published a paper of our first 10 years of work. Really good outcomes, I'll share that with you if you wish. So just to really, in the last 5 minutes, we took the work that we learned in our community work over 10 years and now have brought it to Dana-Farber's main campus, right? Because the patients, once they come to us, patients from historically marginalized communities, they really need extra help in overcoming the barriers that present for them and that we ensure that they do not fall through the cracks. So we're by disease center embedding patient navigators that I oversee and mentor into each oncology clinic so they can work side by side with patients. And really one of the most significant things, and I'm going to, is that this slide is really what the patient navigation program is about, right? That every little gap between each specialty is a potential for a patient to fall through and get lost to follow up. And our navigators help prevent that. And they accompany patients physically. So this is a really big success when somebody meets a person at the front door and says, I'm here for you. I'm not just going to physically show you where to go and, I'm going to take notes for you if you're overwhelmed. I'm here. I am here just for you. So I'm going to, lastly, we have started an ambulatory safety net. So this is about colon cancer screening in the Merrimack Valley, and we've partnered with Lawrence General, Holy Family, and lots of different community centers to help streamline the process, to help provide culturally humble education and also, provide accompaniment. A lot of patients in the Merrimack Valley are immigrants, are just don't have that person, that extra person at home that can accompany them to a colonoscopy. And so that's another big outreach effort that we're doing. And I think I did pretty well. Yes? 20 minutes? Thank you. Too short, too short. I need 2 hours.
Thank you. Our next speaker is Alice Morey, who is an associate professor in our new urban public health department in our college, Manning College of Nursing and Health Sciences. So Alex.
Before starting with a rather different talk, which is going to be very environmentally focused, I'd like to acknowledge all the faculty at UMass Boston who work on similar work that I'm going to present, the impact of environmental change and climate on public health. I think it's important. I'm sure I have missed somebody, and I apologize. I've tried to meet each and every one of them, and I've only been here like 18 months, so it's been a process. Also, two of those faculty are actually authoring this book, available in May. And since we're talking about books, there's another book coming up in 2025 by one of your colleagues. And there's a third book right here, which actually gives the title to this talk, and also was one of the books that inspired me to leave my hometown in southeastern Italy, and the pollution that darkened our skies and made them yellow, which I often noticed when I crossed the straits to Greece and for summer jobs and saw the blue sky and thought, why is that not like home? And so I left to come here to seek an education and research, which was not really available to me where I was. I was 17, like our chancellor, same age. So I'm going to go through 3 examples of how we can map and solve environmental health disparities. And again, this is really big picture, because we are public health, and we're doing public health, and we're doing environmental health, and that's the study of health in its greatest context, as I define it for my students. So the first one is resetting pollution standards. The story starts up on a mountain in the middle of Europe, where people have been producing and being industrious for the longest time, where we extracted an ice core about 10 years ago. 210 feet long, and you should appreciate more that I actually converted that to imperial, which makes no sense to me still. 72 meters, 72 meters. And you can see the layers on the ice core. Each of those layers is a winter. Right? And this, what does an ice core do? It gives us an insight, just like the Jurassic Park mosquito and the amber. It gives us an insight into pollutions going back well before science was science, the way that we understand it today. Why is that important? Well, because if I show you this picture of pollution right here, you might think that we're doing pretty well, right? Clean Air Act worked. Clean air legislation works. After abatement, 1970s, we have no longer pollution, lead pollution, so it's toxic. We're doing well, right? This is a very small part of the whole story. The reality is that we're right here, and zero pollution looks like this. So in fact, our current levels are 284 times higher. And we know that because through this record that we sourced from a mountain and analyzed with lasers, and I'm happy to tell you about all the new fancy stuff that we invented to do this in order to preserve the ice, because climate change is destroying the record of climate change and pollution. We found that the only time that we had clean air was during a 5-year period during the greatest pandemic in terms of a percentage of dead, the second pandemic. So comparing the two, we now know what the standard for pollution should be, and those standards get reset constantly. But this particular article showed, our research showed, how much we have polluted and how the standards should really, how much standards should really go down. Usually we just, when we ask what's normal, what's the standard for pollution, we go back 50 years at best, maybe 200 years if you're really lucky. Nobody goes down back to where we evolved, the time, you know, when air was clean. Well, as my colleagues in the Simon Fraser University have shown, any increased pollution, particularly toxic metal pollution, exposes us to greater chances of cancer and also cardiovascular disease, particularly pertaining to lead. This article went out, had a pretty good effect, pretty good rankings, and news media took notice. My dean asked me to show solutions throughout. This is a solution to me, communicating our science so that policymakers and the public can take notice and demand change. If we don't do that, it's the equivalent of the tree falling in the forest and nobody listens. This article continues to make waves. This was last couple of weeks ago, National Geographic. We reset the standards for air pollution worldwide with this article. By the way, inequity. On the left, European pollution, clean air legislation ensues, and the pollution starts. So we did not stop polluting, we just moved the problem to Asia. These are two articles from my team. This is the inequity, and nobody complains, right? Because we now are starting to hear, only in the last decade, complaints about air pollution in Asia and new legislation to address that. The COVID-19 pandemic confirmed our findings that, in fact, during pandemics, pollution goes down and we can actually get a glimpse of what clean air should look like. And this is one example. When we first published our findings, there were some doubts. And we also saw that air pollution is an aggravator of death rates from pulmonary disease and other respiratory disease by 15%. 15% worse death rates for those who were exposed to air pollution. Why does this matter for inequity, for health inequities? This is a map, a redlining map some of you will recognize, Baltimore, one of the most segregated cities in America, arguably. This is a map of lead risk. This is a map. It's a little slow because the animations are Oh, this is a map of St. Louis, Missouri, where I went to college. This is a map of lead risk. The red line districts have the highest risk for lead pollution. Ongoing, today. That data is today, 100 years after red line. I gotta go really fast because I have 20 minutes. Each one of these could be a talk. How climate affects pandemics is the second focus on my research. This is also really timely. And I gotta, just for a second, ask you to think about time as a line. Again, I go back in time a bit. From 1 to 2024, there is no year zero. And if you divide time in sections of warmer and colder periods, this does happen because of volcanic eruptions, all sorts of natural things. Slight changes compared to what we're doing today with man-made climate change, with man-made emissions. Turns out that a transition of these periods, pandemics happen. Why is that? First pandemic, 542, the Justinianic plague. 1347, second pandemic, 60% dead. You just saw the effects. Cholera pandemics at the transition to the 1800s, then the Spanish flu, and then 2020. We don't think COVID was climate related. Why does that happen? Because when nature is stable and the environment is stable, there are barriers between those sources of disease, usually in the environment, right, and us. And so those viruses and bacteria just don't cross. Those barriers are there, whether it's because water is separated, food is separated, animals have habitat. When nature is attacked by such a thing as climate change, which shocks everything, those barriers are shocked too. And this is systems dynamics, and I'm really simplifying it, so I apologize if it's a little simplistic. And so when we shock those barriers, the chances for spillover of disease are much higher. And that is what we're observing today. I wanted to test this hypothesis. It was one of the earliest studies of this kind in systems dynamics and multi-proxy data. And I went to the largest pandemic by number of dead, not percentage, but number of dead. 50 million dead, the Spanish flu 100 years ago. Very understudied, nobody knew where it came from. First thing I did was use a tool from a Climate Change Institute, where I'm affiliated, free tool for everybody. You can do this yourself in 5 minutes. And I found a blob. You don't have to be a climate scientist to recognize that that's anomalous. It's a low pressure system, kind of like what we had here yesterday. Over Europe, lasted 6 years. And this is September of 1918, when the second wave of the Spanish flu killed the most people. That was a clue. Okay. And I went back to my I-score and found the record for rain for that period and graphed it. Interesting. And then I had to tally up all the dead, because nobody had ever done that. We had a dashboard for that for COVID for every minute of every day for the last 5 years. We did not have that for the largest pandemic in the history of mankind that killed 10 times more people. Whoops. There we go. And there was a telltale double peak right there. Now, we modeled this, did all the statistics, et cetera, but just to show you that's what came out. So second set of data, and then a third set, we actually think that by bombing Europe for the first time, we created aerosols, particle matter, PM10 particularly, that function like magnets in the air and brought together water into droplets and made it rain. And that is why we have, and that's how it works. That's why we have the stories of battlefields during World War I, totally full of water constantly, people living in water. The same climate anomaly stopped the migration of birds, and I had to actually go outside. I have a PhD in a few things, but not ecology and not ornithology. And I had to ask my colleagues at Harvard for help. The same climate anomaly interrupted the migration of birds. Birds turn out to be the vector for Spanish flu, H1N1, which in September, when the wave started, reached 60% infection rate because the ducklings and the newborns are not, are immunologically naive, as we would call it in public health. They're not equipped to fight off the virus. So we have water spilling over into trenches where people are living, drinking, fighting, sleeping every day. And so it was quite literally a perfect storm. And so we found the origin of the Spanish flu. 50 million dead, 500 million infected. That's 1/3 of the population at the time. It's 1 in 3, and most likely everybody got it. It's just two out of three were asymptomatic. By comparison, COVID underneath, even though we have almost 8 times the population today. Article also did well. Again, media took notice. Again, I think this is a solution. We should communicate our findings. Doesn't happen by chance. You do not go viral by chance. You have to work on this, creating the connections with press, and that is one of the solutions that I suggest and recommend. Why is this important? Because there are migrations happening around us all the time. This is supposed to move, but it's not moving. I'm demanding too much of the PowerPoint. Okay, well, there are migrations happening around us all the time, and if we change, whoops, if we affect them with climate change, I don't know what's going on here. If we affect them with climate change, the net effect is that we are increasing our chances of having a pandemic. We need, oops, I don't know what's going on here. Sorry. We need to stop thinking in a linear fashion, cause and effect, but actually start thinking in terms of multiple causes, multiple effects, creating the reality that we're in. And that is the interdisciplinary work of public health in the 21st century and the type of work that I do. And using our chancellor's own words from his inaugural address today, which I added while I was sitting in the audience, we need to embrace complexity and disciplinary diversity in this case in order to actually do this kind of study and prevent the next pandemic. Just to give you an idea, for the last 2,000 years, new epidemics have emerged when people change the environment by deforestation, reduction of wildlife habitat, animal domestication, wildlife trade. If you don't take nothing else out of this lecture, anything you can do to stop wildlife trade as #1 threat to public health, #1. And man-made climate change. The diseases that come from this shortening of the distance between us and animals are on the board. The orange ones are rising exponentially. And they're affecting mostly people, minorities, not only in the United States, but also around the world. The vectors are extending to the north more and more as a result of climate change. This is dengue today. It's endemic mostly in the global south. And the global south is leading in solutions to it. This week, rolling out the first vaccine against dengue in Brazil, and also introducing mosquito species that can reduce the number of mosquitoes and vectors. The same goes for malaria, which kills millions of people every year, as much as half a pandemic every year, half a COVID pandemic, and we don't talk about it. Why don't we talk about it? Because the people dying don't look like Americans, or at least don't look like they're just not registering. And Lyme, right in our backyard, 500,000 cases every year. This map I created shows how much hotter the Northeast has become because of climate change. And here are the cases of Lyme superimposed. They follow a 3-degree line with double the length of the summer, allow ticks to reproduce twice as long, and this is the result. Can't go into the woods because of it. And we do not have a vaccine because anti-vaxxers made it impossible for the few who actually did vaccinate to vaccinate in the 90s. And today we have candidates for the highest office who hold those positions. Heat is affecting people as well. And it's changed, as I just showed you, and it's in urban areas from this study that I created, very precise urban areas measuring temperature over the summer. You can see that we are well beyond a 2-degree world. And that is what's affecting the emergence of infectious diseases. Here are the solutions: education and research. Educating students in latest environmental health discoveries, as we do here. Funding systems-based and nature-based research and solutions to environmental change, and also strengthening community health education. We do all of this at UMass Boston. UMass Boston is a leader in this. That's why the first slide. And my center, my lab, ECHO, does this as its work. Policy and advocacy, you need to vote, and vote people who don't, it's not believe in science, understand science, because it's not Santa. People who don't believe in science need to be voted out. It's that simple. It's a matter of life and death. So you got to vote. You got to prevent the regrettable substitution and fight inertia. Regrettable substitution is when we take out fossil fuels and then we start mining for lithium. That's also finite. For a solution that's not a solution. I got a whole talk about solutions that aren't. Ask me a question about that. Rewild historically red line areas so that we can fight heat island effect, communicate science, boycott wildlife trade, consume less energy in personal commitments, and commute less if you can. But personal commitment, we always put the burden on the individual to change their lives. And meanwhile, we're giving $300 billion in subsidies to oil. So I can't really ask you to change until the government changes. And finally, start valuing the environment and nature and ecosystems as if our lives depended on it, because they do. We're doing this with lots of programs here at UMass Boston and publications that I've created since I've been here. This is my group. And thank you.
Thank you so much. If I can ask all three speakers to come up and take a seat, try not to fall off the stage. And if you can raise your hand for a question, we have a microphone runner here. I'll start with a question now. It seems that we have connection between all three talks, right? And that is, for whatever we're looking at, communities that have less resources are the most affected. It seems to me that the solutions that we put out requires rather substantial changes that needs to be implemented by those individuals and communities that have resources. So how likely are we actually to affect this for the communities that don't have the resources?
Sure, I'll start. So those are the communities with whom we should focus. And I think that, in the instance of cardiovascular disease and physical inactivity, I mentioned in my talk that it's a matter of it becoming normal. This is something that can happen, and I'm just listening to both talks, and you're right that people who are more physically active have fewer risk factors, whether it's cardiovascular disease or cancer. Physical activity reduces fossil fuels. So you're not using cars, you're not riding the bus. If you're walking, it's good for the environment and it's good for you. And that could be done in any community. Again, redlining is a problem, and it's a problem for active transport out of inner city communities. So it's a responsibility for policymakers and developers to make it possible for people to be physically active no matter where they are. And that's a community redesign. And it is really possible. And then changing the social norms so that people are more physically active.
Thank you. Well, I think about this a lot, right? Looking at the migration patterns of the communities that I've been lucky enough to work with, right? And so much of it is related to climate, right? We cannot take this out of context. Our patients are leaving the African continent because of drought and so forth. I mean, these are all things, that we created in high resource countries with 2 SUVs and these enormous houses and so forth, right? And it goes all the way, right? And then back through, like I mentioned before, South America, and then folks are coming here because they have to, because climate, there's lack of screening, like the distribution of resources is just absolutely inequitable and needs to change. I can go on and on, but I want to pass this to you.
How likely is it? I think, the people who can really make a change are in government. It's that simple. That's where they are. And we, in this country so far, have a democracy, and hopefully we'll continue to do so. And I think we can use our power, our democratic power to change that, as I said. However, when I say vote, you can also vote every day with your dollars. And I'm kind of shocked that still there isn't, perhaps because of the litigiousness of American society, we don't have a system to actually boycott things that should just not exist, right? We have apps for everything, but we don't have an app to basically tell you a grocery list that has a lower carbon footprint, or buying things or services that have a lower carbon footprint. That can make a difference. This is a capitalist country. Market pressure is your friend. So use market pressure to change things. And I think that with leadership from both scientists, advocates, and policymakers, this can be our future. But we have to fight that inertia and fight that kind of hopelessness. We always talk about hope, and it's kind of inaction. Just act. It really needs to happen. We need to believe that this will happen, and it will happen.
Thank you all for your presentations. I really appreciated all that you shared. My question has to do with Ludmila, I think.
Yeah.
Yes. You started this outreach program about 12 years or so ago, and I can see you have hired a lot of diverse patient care coordinators and advocates. My question is, how did you begin in 2012 to start to build that trust with the community? What were those steps? I mean, we see the end result thus far, but what was the beginning like? What were some of the barriers? What did you do to persevere so that you are where you are today? Thank you.
Thank you so much. That's such a great question. And, I did a presentation at the Dimmick Center, and the medical director said to me afterwards, Ludmila, this is the first time that somebody has used the words, "We are here with the greatest of humility," right? She said, we always are considered as the ugly stepchildren, as primary care providers serving the most, marginalized communities. And we showed up, and we showed up and we stayed. And week in, week out, we've gone to the clinics through the pandemic and, earn trust one patient at a time, one conversation at a time. And not just with the patients, which, that's my heart. I have patients that I know now for almost, I always have to think how old my son is, like 13 years, right? And at the community providers, and folks have said to me within the health centers, academic medical centers are very extractive. They come to us when they need something. They come to us when they need the diverse sample. They come to us, XYZ, and then leave. But we're there, in service and based on, social justice principles. And we didn't get funding from Dana-Farber. We got funding, we got a gift, a significant gift, philanthropic monies from the Kraft family to start. And we're still operating mostly on philanthropic money. So all of the staff that you see, all my incredible team, and that's my sort of my legacy, right? I can't change how Dana-Farber is right now from a leadership structure, but I can absolutely affect what comes next. And all these young women that are from, they're the future of our institute. So I invest a lot in that. You're welcome. Do, do, do.
Um, this is incredibly congruent with some things that are going on at the university right now. And there are a bunch of people who are rediscovering what community engagement means, a university mission, if you will, a center point for us through the Carnegie classification. And I've spent, just in the spirit of full disclosure, I've spent over 25 years in community engaged research with women living with HIV infection. And boy, trust with a capital T is absolutely important. But I realized that all of those men and women, in my case, women living with HIV infection, they trusted other women who look like them, who were infected like them, to give them a message. So I wondered if you could just comment. We as scientists have a dilemma. There's an image that we have of being very brainy and doing all this work. A lot of people don't trust us very much, or they don't really read our work or understand our work, but they will read and listen to somebody who looks like them, who understands their situation and gives a message. So I wondered if you can comment about that as a point of intervention for all of you, because I think it's been very meaningful for me, and I know it works.
Maybe I'll start and then pass it. So, for me, it's been an incredibly, for me, it's been an easy experience to connect with diverse groups, and I have seen providers of color, and that can't connect with a patient. And I'm not at all, I feel that when you're in a room, in a tiny space with a person, irrespective of your race or ethnicity, people can read your intentions. They really can. And it's been, of course, at Dana-Farber, we do not have enough diversity among every, nursing, physicians, et cetera. But, I think if you truly live and believe in cultural humility, not just as a talking point, but if you live it, and I wake up every day, re-examine, how do I take up space? When do I pass the mic so I don't talk too much, and all of that. It's true. Like, you have to think about it in every interaction throughout the day. And PhD doctor.
So that's a great question. And when we do community engaged research. But just because I'm a Black woman doesn't mean that I can connect with other Black people. One of my PhD students is Mexican American, from Southern California. He's bilingual, but he understands he's from Southern California. We live in Indiana. So we understand that there are differences. When we're recruiting vulnerable populations, the way I explain it is that most of the data we have are based on white men. And so the medical decision-making that's happening for you is based on the physiology or anatomy of a white man. And in order for physicians to make evidence-based decisions about you, it is really important that you share your data with us. I mentioned in my talk that we're guided by ethics. And so what has historically happened to vulnerable populations in science can't happen anymore. And it won't happen anymore. And it is our obligation to protect you and to protect your data. But we sit down and have these serious conversations. We don't just show up with our informed consent forms and say, sign here. We actually read the informed consent forms to them. We don't make an assumption that anybody can read. And we don't make an assumption that people understand the language in these really difficult informed consent forms. And so we stop and we say, what questions do you have at the end of each paragraph? And we encourage people to ask questions and to question us at every step of the research. And then when we're done, we go back to our community partners and we tell them what we've learned and we ask for their advice. And this is part of trust building, but it's also, you know, our community partners have degrees just like I do. The people they serve don't necessarily. And so there's still a divide there. And so we also try to have other opportunities to say, you participate in this study, we'd like to share with you what we learned. Journals are important. We need them for tenure and promotion. I don't anymore. I'm a full professor, but I'm looking at Alex. So the journals are important, but they're meaningless to people who are never going to read them. And so it is really important for us to get out in front of the population in other ways, including just going to their community meetings and talking to them about, this is what we learned about you. Thank you for participating in our research.
I thought I had news mostly. I was actually shy about putting all the news up there, but you seem to pick up on my journal articles. Yes, I was signaling to my dean, hey, look. I'm going to give you a perspective that's slightly different of an immigrant who has done work abroad. And many of I actually currently have a pending NSF grant to do exactly what you just described in Quilcaya, Peru, where we extracted an environmental record with the consent and permission of local people, indigenous people. And we want to go back and do it precisely what you described. Communicate that information, what we found to them, why it matters, and do some more work. Often when we do this, we carry, as Americans, I'm now a US citizen, we carry our categories of how we see each other and others to these other countries where those categories just don't exist. For an immigrant like me, actually having to check a box, still very shocking. Believe it or not, if you had to check a box for race in Italy, you were a certain kind of person. That was not a very good person. It's absolutely illegal, both in Germany and Italy, for reasons that you might guess. So when we bring our categories with us to the field, in places like South America, where we're hopefully going to go, or even Australia or Southeast Asia, where I've done work, we can't take those categories with us. So the answer to your question, Rosanna, is you really, at least in my experience, have to be very quick on your feet and read the room and read who you've got in front of you, read the body language. There's a great book by Joe Navarro, FBI interrogator, chief interrogator, Cuban, who came to the United States, much like me, very early. He was 9, and he spoke no English. And he had to learn body language, otherwise he'd get beat up at school. And he made this a science and wrote a book about it. Became chief interrogator for the FBI. This guy's never tortured anybody. You can see if you're lying because of body language. We are completely we don't know about body language. It's not taught. I've never been taught body language, and yet it's crucial for me to understand where somebody's nervous. If, you know, we are in their house getting samples from their backyard. And so you really got to read people and be, as Ludmila said multiple times, very humble, culturally humble. I love that. I actually saw myself in some of the things you've described, and I really appreciated that presentation.
The world, all 3 of you, because from each one of your talks, I can feel the passion, I can feel how dedicated you all are, and how even talking about your work and what you've done over the years is going to help all of us in this room. And so I really appreciate what I've heard today. Thank you.
Thank you so much. Thank you.
I want to thank you all for coming, but before we sort of end this session, I thought that since we have these experts here, and change has to start with each one of us. So if each one of you can tell us the one thing, only one, that we need to do when we go home this evening or tomorrow to affect change in your area, give us one thing that we can all do.
No pressure. Oh, bye to me.
You had the mic.
Oh, you started speaking.
Yeah. He just wants to follow my answer. I would say, lots of chocolate and good coffee. But in all honesty, what I say to the nurses, diversify your experiences. Get out of the ivory tower, just go. I take my kid, he's Native American, but we go and just sit where the new Mainers are. We live in Maine, and he plays hoops and I talk, and I would never know all these stories unless, that's my comfort level too, but diversify. Step out.
Okay, thank you.
Walk. That's the answer. So, when I lived in Rhode Island, I had a neighbor. We were both pregnant at the same time. Our children were born on the same day. But I watched her one day, she was pregnant, get in her car that was at the top of her driveway, drive down the hill and across the street to another neighbor's house and up the hill. It probably took her longer to get her keys and get in the car than to make that act. And I was like, why did she not just walk? If there's a destination where you can walk rather than driving, walk. That's the answer.
My answer would be probably get a puppy because it makes you walk. Mine makes me walk 5 miles a day at a minimum. It's life-changing. But my answer would be, and I know this is kind of trite, but make an elevator pitch, because we're mostly scientists here. Make an elevator pitch of your science. If you had 5 minutes with, not even 30 seconds with a journalist, make an elevator pitch for them. Why does your science matter? Again, if we don't communicate our science, it's not out there. It's just for us, like Dr. Keith said, it's for our deans and our colleagues, but it's not really for the public. But we all do this because we want to change the world. So make an elevator pitch. 2 sentences. What do you work on? And just in the way that you want to see it on the New York Times front page. Do that for yourself so that you have it, because that will happen. Ask Lisa. She knows it'll happen someday that you'll have a one-on-one with a reporter and also the Massachusetts General Court. So yeah, that would be my advice.
Thank you, everybody, for coming. Thank you, our speakers. And I suggest that everybody walk out of here.